Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm your host and the co-author of the book Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, Dr. Rebecca Bernard. As we often discuss on this podcast, there's a reason why physicians have to spend at least 15,000 hours in training before we're permitted to care for patients independently. And that knowledge is not just so that we know how to diagnose and treat patients, but it's also to help us learn when a situation is not serious and doesn't need intervention. Today, I'm being joined by emergency physician Dr. Andrew Wilson, to discuss a case in which improper training or inadequate training may have led to an unnecessary emergency room visit for a patient. Dr. Wilson, welcome to the show.
Thank you. Thank you, Dr. Bernard. Thank you so much for having me.
So you recently had an experience that really demonstrated to you why it is so important to have the training that we go through to become physicians. Tell us about this case.
I'll be honest with you, it caught my eye right away on the tracker board as I was, screening over the waiting room, making sure that patients were being triaged appropriately. And I did see this complaint pop up, sent from urgent care abnormal EKG. And so it gets my attention. I want to know what this EKG is. Is this something serious I need to react to right away? And so the triage nurse brought the EKG up to me, and I looked at it, and I was a little baffled, to say the least. So I said, "Well, there's got to be more to this," and that's when I basically said, let me go see this patient out in triage."
And so here you have this young patient, young man, he goes in for an employment physical. And as part of the, physical requirements, an EKG is done. And then I'll just mention, as a primary care physician, we don't do routine EKGs for just general reasons, right?
Right. Yeah. So I don't know what the indication was. The patient did have a slightly slower pulse that I would say is still appropriate in a young, physically fit male. It was in the upper 50s, and that's absolutely not out of the ordinary, especially with no complaints or symptoms. So really, I agree, was no real indication for an EKG. I wasn't aware of any requirement for them as part of their physical, but it could have been. I'm not sure. Yeah.
Okay. So the patient goes into the urgent care, they get a physical, and as part of this evaluation, the nurse practitioner does an EKG. And the EKG comes back with some findings that, at least that the computer read. And tell us a little bit about what those findings were.
Sure. So a couple of things that you'll see on there, which I know as a physician you'll recognize, sinus with sinus arrhythmia. Sounds scary when we hear the word arrhythmia for non-trained, but as you and I well know, this is almost always a nothing. This can vary with respirations. As a patient breathes, you'll get a slight variation in that cadence, but still an absolute normal sinus rhythm. Also more likely in a patient with some sinus bradycardia, which this gentleman also had, meaning slightly slow heart rate. Of course, he was in the upper 50s. So really, again, nothing concerning with that reading either. The other thing that was mentioned in the CKG was a possible conduction delay, with a pattern that was more consistent with the right bundle branch. However, again, not a concerning finding. Even it wasn't even truly a full bundle branch at that point. I think his QRS was right at the threshold, but had that classic pattern.
So a person that maybe doesn't know very much about EKGs, has minimal training on them, looks at a computer printout and a computer interpretation, gets scared because they maybe don't know what those words even mean, or maybe they sound scary to a person without proper training. And so their first inclination is to tell that patient, who is perfectly fine, by the way, go directly to the emergency room. Yeah. Now, that patient, I'm imagining, must have been scared. Were they when you saw them?
Yeah, he said, I felt okay. He's like, I feel fine. I don't have any complaints. He's like, I wasn't really worried, but I didn't understand why I had to rush straight to an ER. So he was genuinely concerned. Is there something on this EKG that's dangerous for me, or going to be something that now I'm going to end up with further testing, or anything like that? Thankfully, this gentleman was very understanding. He said, I'm just trying to do what I'm told. He's trying to maintain his employment, and so following through with what this nurse practitioner instructed him to do. And so absolutely, as you said, we went out, checked on him. There was absolutely nothing wrong with this gentleman. He's been having no complaints. I checked, review his systems, his history with exertional tolerance, everything coming back fine. Physical exam, completely unremarkable. And so I started explaining to him a little bit. I said, well, I'm afraid, you've wasted your time. And I really felt bad for him. Now he's going to get an ER bill. And I don't know what his coverage situation is, what his responsibility might be. Really a waste of healthcare dollars and time. But I was concerned enough that, with a nurse practitioner sending in a patient like this emergently to an emergency room, following what is considered a completely benign EKG, that there wasn't adequate oversight. And so that's when I said, I'm concerned. This is a topic that definitely concerns me. And so I wanted to reach out and say, what is the situation there? What's going on? So I did take the time to reach out directly to the nurse practitioner after a fairly long hold, was able to get on the phone with her. Of course, as a physician, you're sort of a little frustrated, and that frustration you're kind of holding back. And I'll be honest with you, she totally disarmed me instantly because she was so much more frustrated with her own job. And when I asked, is your supervising physician there? No, she's out of town. And the other doc that I sometimes have is not here. And as you may know, in the state of Florida, nurse practitioners are allowed for some independent practice in the primary care setting, which does carry over into urgent care settings. So she had no supervising physician to cover her. She was very frustrated with her working conditions. She said she was expected to see all the way up to 50, 60 patients a day. And she said she had already put in her notice. She had some choice words for her take on that particular job and role. So, I felt bad for her in that scenario. I was frustrated with her, but instantly kind of turned towards almost just empathy with the situation that she found herself in, knowing that she didn't have the skill set. When we talked about the EKG, she said, I know nothing, he didn't seem like anything was wrong with him, but I'm not allowed to, clear somebody if the EKG doesn't say normal sinus, normal EKG. So anything abnormal, she wasn't allowed to clear him. And so that's why she ultimately decided to send him, not understanding fully what she was looking at. So,
right. Or thinking like, maybe before I send, maybe I can't necessarily clear this person, but maybe I can have them come back and see the doctor, or even not to waste a cardiologist's time. But that's probably a little bit better than an ER where you're dealing with people that are, potentially dying, that you might be skipping over because you have to attend to this.
Sure. And it did take time. It took me time to make sure this gentleman was okay, that I wasn't missing anything. It took the time. That's part of why I called her, to make sure I wasn't missing something, because this seems so obvious. Why would they send somebody in emergently like this? Surely there's something else I'm missing. But at the end of it, there truly wasn't. And then I felt bad for this individual. So I took the time then to connect with my billing department personally, and then also the hospital's registration department and billing, to try to ensure that he doesn't get any bills from this, because I thought it was not his doing. It was the doing of the healthcare system and the failure of the system.
I think your point of the whole system being broken is the most important take-home message here, because what we're seeing is a nurse practitioner who's being put in a situation that they're not prepared or qualified for, or maybe they could do certain parts of it with proper supervision, which to me means a physician on site, or as certainly accessible, at least ideally, again, on site. It sounds like she had somebody, but they weren't available from the way she described it.
It didn't sound like they were normally there. It didn't sound like an exception. And she did express that was one of her frustrations with this job, and why she was ultimately leaving. Yeah.
And you wonder how many urgent cares are also, as you mentioned, taking advantage of nurse practitioners and PAs and putting them in those situations.
I think with the changes in the pandemic, we saw a lot of nurses leaving the bedside. With the growth in nurse practitioner programs, especially, we've seen just droves of nurses leaving the bedside without adequate hours of experience, right? These aren't nurses that have 15, 20 years of experience at bedside. So they're already taking very little clinical knowledge with them to begin with. And then coming out and they need that job, and so somebody's going to fill this role. I have no doubt they'll have no problem getting someone to jump right into that same scenario, as unsafe and stressful and as it is.
Which is not to say that doctors don't make mistakes, because I hear that all the time. People say, you're all the time harassing nurse practitioners and physician assistants. Well, doctors screw up and make mistakes. And that's actually the point, is that we do make mistakes, and we try very hard not to, and we train for a long time, but we're humans and we are going to make an error. So if you have somebody with all these hours of training making mistakes, how many more mistakes are going to be made by someone that has the fraction of training?
Absolutely. Yeah. And that you hit it right there, nail on the head. There's always going to be exceptions. There's always going to be mistakes or misses. But like you said, what's the likelihood? What's the percentage of that occurrence? And when you don't have the right training and you don't have that experience, that goes up drastically. And that is absolutely what we're seeing.
I can tell you, I certainly appreciate that you and your colleagues are there for the time that one day I may need to go in there and I want to look up from a gurney and know that there is a board certified emergency physician waiting there to take care of me. As fallible as you are, and we all are, I know that you'll be doing your best and that you've trained for a long time to be able to take care of me.
Absolutely. And we hope to never have to be your emergency doctor, but we're there for anyone that needs us. And I'm very proud of the work that we do and the team that we have, and the PAs and nurse practitioners that work under us and directly with us, right? They are very effective because they are at our shoulder. They sit beside me in the room. We talk about every case. We go over the cases. I see those patients. If I have any concern at all, I take over the care at that point and direct it 100% if I need to. So that level of supervision is really where the sweet spot is, I think, for the nurse practitioners and PAs. And unfortunately, we're just getting away from that, and we're seeing that it's lost, so it's out of control once it leaves that physician arm reach. Yeah.
Yeah, studies show over and over again that when nurse practitioners or physician assistants work together with physicians under physician supervision, that patients get great care. But there are no studies showing that that's the same when physicians are not involved. And I'm talking about directly side by side working together. So I totally agree with you, Dr. Wilson. I really hope that we get back to a time where the needle starts to move again towards actually working together truly so that patients can get the best care.
I had this conversation with my parents just recently, even though I feel like I talk about it with them. But when I actually talked about like the number of hours of training, they know, they paid for mine, so they know how much I went through. But when I compared it to what nurse practitioners have to do to come out of school and be independent practice in many states, they were blown away. They said they had no idea. So that's what worries me, is that folks who even have some insight to what's out there really don't understand it and don't see and feel that difference. And that's what I think we just have to continue to highlight. There is a reason why we are medical doctors, DOs, because of all those hours of training and what that means, the difference. So yeah, keep getting the word out, and thank you for all the hard work you do to do just that.
Thank you so much to my guest, Dr. Andrew Wilson. If you'd like to learn more about this topic, I encourage you to get the book Patients at Risk: The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. It's available at Amazon and at barnesandnoble.com. And if you're a physician and you'd like to get involved with our mission, which is advocating for physician-led care for all patients and for truth and transparency among healthcare practitioners, please join our group. It's called Physicians for Patient Protection. Our website is physiciansforpatientprotection.org. Thanks so much, and we'll see you on the next podcast.